Thank you very much. Thanks for inviting me to the CVI 2019. I'm going to be talking about how to find a culprit lesion in acute coronary syndrome. Let me start off with disclosures. With a case, a 56-year-old female presenting with new onset chest pain and positive troponin, non-ST elevation in my presentation. You can see from the angiography, from first look, relatively what we call non-obstructive, maybe some hazy lesions you may be able to point out, but no obvious culprit. And this is not an uncommon presentation in somebody coming with non-ST elevation MI, more so non-STEMI obviously than ST elevation MI. If you look at the spectrum of non-STEMIs, half of the non-STEMI presentations have a single culprit lesion. Less than a third of them, of course, have occluded vessel. 10 to 15% of them have multiple culprit lesions, and about a third of them, a good portion of them, have no identifiable culprit by angiography. So not an uncommon thing to see for us. So I divided up this angiographic presentations of patients presenting with non-STEMI into this spectrum of obvious culprits, your ambiguous angiography, some hazy lesions, maybe a tortuosity, maybe some stenotic lesion with no obvious acuity to it, multivessel disease, which is relatively common as well, and lastly, Minoco, myocardial infarction with no non-obstructive coronary artery. So not much is to be said about obvious culprit. You can have on angiography, you may be able to notice a plaque rupture with a thrombus with subtotal occlusion, like in this case, which is a stent thrombosis. One thing I would say is you got to study angiography carefully before you say that, that is the culprit or you miss a culprit lesion. This is a presentation of a patient who actually presented with inferior ST elevation MI, and the operator looked at the LAD, felt that was a wraparound LAD, which was, and looked at the distal LAD, felt that was the culprit. Went ahead, did some aspiration thrombectomy, some vasodilatory agents, and sent the patient back to the floor. Patient continued to have chest pain, brought the patient back, and if you look at the angiography in different angulation, you see there is a lesion hiding there right in the ostial of the LAD, which turned out to be a plaque rupture. So you got to study the angiography, especially when you have a distal lesion. Want to look at the proximal parts of the vessel to make sure you're not missing anything. And of course, you can have no apparent angiographic culprit. I mean, if you look at the angiogram all over in different angulations, you may still not see anything. And you got to look at the clinical data to kind of help you focus the effort in identifying where the culprit could be. EKG and obviously transthoracic cardiogram, LV-gram can be very helpful to identify regional wall motion abnormalities to kind of help you cone to that area of the coronary that you can perhaps study more. Of course, you can have normal wall motion, which may be not helpful, or you may have apical ballooning, which then would suggest maybe a Takotsubo cardiomyopathy. So from the initial presentation angiography that I had, this was the echocardiogram, which shows some apical wall motion abnormalities, which could help you out, figure out where that culprit is. And once you figure out which artery maybe, or which region may be perhaps the culprit, you can use imaging acquisition to help identify the culprit. IRIS or OCT could be either of them could be helpful. Obviously, OCT would have better resolution to identify the underlying plaque rupture, erosion, or calcified nodule, which can be very important in guiding your medical management, especially if it's a plaque erosion. And it's also, with OCT, maybe a little bit easier to identify a thrombus. Like in the top panel here, on the left upper side, you have a proximal LAD lesion, which appears to be a hazy lesion, likely a thrombus, as confirmed by OCT on the right upper side. And the bottom left side panel, mid-LAD lesion, which was thought to be either plaque rupture, was a SCAD, and of course, the IVUS and OCT in this case, and the side underlying plaque rupture with overlying thrombus. So OCT and IVUS, either of them can be extremely helpful identifying plaque, the culprit plaque. A multivessel disease is, again, a very common presentation, and identifying the culprit plaque vessel can be very important. And there is debate, of course, ongoing debate around whether to do culprit only versus complete revasc in the setting of shock or no shock. And as laid out very nicely in this recent publication in Circuit Intervention, where they took patients who presented with non-ST elevation MI and did cardiac MRI during that hospitalization to look at whether or not the culprit vessel was identified correctly or not. I'm not sure if you guys see the cursor, but so in the 63% of the patients, they were able to identify, the operator was able to identify an infarct-related artery, and 41% of that 63%, it was in fact confirmed that was the correct culprit vessel. But 9% of the time, a different vessel was identified, and 8% of patients, 8 of those 63, a different diagnosis was made. And out of the 37% where a IRA was not identified, 22% the MRI was helpful in identifying one, and 7% another diagnosis was made in myocarditis amyloidosis. But despite that, even though MRI can be very helpful, you still could have cases where it's really difficult. So you have the 81-year-old, for example, here with moderate aortic stenosis presenting with non-ST elevation MI, troponin of 3. They have a left main lesion that's confirmed by IVUS. I don't have the images here. And an ostial circ and mid-circ lesion. What is the culprit? What is not? I mean, it's very difficult to identify. And despite having all the information, this patient had the echocardiogram, was not really helpful in focalizing any particular lesion, and they ended up undergoing staged impella-guided PCI of the left main bifurcation. Or you can have it in this case, a 67-year-old male with chest pain, non-STEMI elevation, troponin of 4.5, EF was 35% presentation. His echocardiogram was global hypokinesis. I mean, what is the culprit lesion in this case? Very difficult to tell. Is it the LAD? It's got some slow flow in it. Was it one of the septals went down? Again, very difficult. In this particular case, again, after discussion with the patient a day later and the surgeon, the patient underwent impella-guided LAD CTO and RCA PCI relatively actually easily. And then at the other end of the spectrum, we could have MI with non-obstructive coronary arteries. So you look at the angiogram, you still cannot, there's no wall-motion abnormalities, you can't identify a plaque. And the definition of MI with non-obstructive coronary disease or MINOCA is essentially elevation of cardiac biomarkers with ischemic symptoms and EKG changes and no epicardial stenosis greater than 50%. And it's a good portion of MI presentation, 6 to 10% of MIs, two-thirds of them, two-thirds of the non-STEMIs. And again, if you look at cardiac MRI spread of these MINOCA patients, about a quarter of these patients actually don't have any identifiable lesion on cardiac MRI. A quarter of them, MI is confirmed. And interestingly, 33% of these patients actually have myocarditis, and 18% Takotsubo cardiomyopathy. And you have a list of other diagnoses down the line of dilated cardiomyopathy, hypertrophic cardiomyopathy, amyloidosis, et cetera. So this flow diagram I kind of adopted from a European Heart Journal with some modification is how I would approach patients who present with ACS with different sort of angiographic presentations. So you can have your, again, obvious culprit lesion, which would be relatively straightforward. You can use imaging in those cases or not. And you have ambiguous angiography. You got to use your clinical data, again, your EKG, your echocardiogram, your LV-gram, which then would guide you to kind of focus your intravascular imaging and identify either a plaque rupture or a SCAD or maybe no culprit at the end of it. And in those cases, maybe consider a cardiac MRI to kind of help you guide management of that patient. So I'm going back to that first, no, I guess, I'm not sure if it's, there we go. Going to that first case that I had, he ended up going OCT of the LAD, and you can see there's in fact thrombus as suspected, and there's an underlying plaque rupture which was fixed. Thank you very much.